Hey, listeners, we're continuing our series of live bonus episodes from ViVE and HIMSS, where we sat down with industry leaders about innovations and digital trends that are making healthcare easier. Today, you'll hear from Dr. Stephanie Lahr, Chief Experience Officer at Artisight. Let's get to it.
Well, Stephanie Lahr, thanks for having me. I am the Chief Experience Officer at Artisight, a smart hospital platform leveraging automation to, in my opinion, bring the joy back to medicine at the bedside.
Love that.
I am an internal medicine physician by background, training, and practice.
So it's a platform?
So conceptually, we leverage sensor devices, typically cameras, speakers, microphones, RTLS or ultra wideband kinds of technologies to know where things are in space, with this idea that if we can replicate some of the human senses, seeing, hearing, speaking, knowing where things are, we can identify the friction points that plague our clinicians, pull that friction off through automation, and allow those caregivers to return to their centered attention on the patient.
Well, it's the stuff that if it works well, I'd imagine the patient almost doesn't even know or isn't aware. They're just like, that went better?
Kind of. It's interesting. Probably one of the most common questions we get around patients is, and because I have said it, I even said it on stage yesterday at one of my presentations, like, I believe that every health system in the country will have a camera and a speaker and a microphone, leveraging the TV for a two-way video experience. Every room in the hospital, every hospital. And people are like, ooh, really? We're going to put cameras in every hospital room? And even patients sometimes are like, yeah, I don't know what I think about that. And I think it's a bit of an evolution, but it's really intriguing the number of patients and their families who really love it, right? They have access to additional caregivers because you can leverage that system for virtual care. We can monitor you for falling. We can monitor things like making sure the movements in the bed are frequent enough for you to not end up with a pressure wound. All kinds of things that should improve the quality and can improve the experience in a way that, I think one of the things people think of mostly is like, wait, if there's going to be a camera in the room, are you recording? And the beautiful thing is there is no recording. It's all happening in real time. If a clinician's on the other end of it, if the AI is watching it, it's real time understanding and providing cues. But it is going to be an interesting paradigm shift. But hopefully after an initial kind of like, question, it fades into the background and people really, we've seen a lot of patient experience improvements, as well as clinicians that are like, I could stay in my job longer because of these kinds of technologies. So it's an exciting time.
So what kind of traction has there been so far? Remember, like, how long has it been implemented?
So we typically, most of our implementations start with a virtual nursing program or a virtual sitter or some combination of, because again, that gets the camera, the speaker, the microphone into the room. We're using the TV for that experience of two-way video. So, we have 24 health system customers now live in hundreds of hospitals. What's really interesting, though, and fun to watch is most hospitals start sort of a little bit small, try this out, like, where are we going? And then to see them scale up to, again, 1,000 rooms across all of their hospitals is really, really exciting and offers us then a lot of opportunity to collaborate with those health systems and say, now that this infrastructure is there, what else could we use it to do? What other algorithms could we train that would pull more friction off of this interaction, help us learn more about the patient and what we could use to help them? And so, then the sky's the limit.
Yeah, seriously. It's kind of opening my mind here of what's possible. And it would be an evolution. Let's talk about like what some of those burdens or administrative pieces are that does remove for the clinical team.
Yeah, so a simplistic example, because again, by being part of a platform, we function in an inpatient room, we function in an operating room, we can function in a supply closet, we can function in an emergency department. Ultimately, we could potentially even function in a patient's home, and I do think that will be an interesting paradigm shift as we think about hospital at home, for example, leveraging cameras and speakers and microphones on a temporary basis, probably inside of a patient's home. But I think that we'll see people that are willing to do that in order to still receive high quality care, but be able to do it, safely and effectively inside their home. But a simple example to think about the operating room. So in an OR, every step along the way is typically something that we want to have documentation of, because we know that how long a patient is in the OR, how long they have anesthesia, how long different things are happening has an impact on the risks for any kind of postoperative complications and things like that. Most of that documentation, most of that box checking is done by our clinicians. And so imagine being a circulator nurse in an operating room who is trying to work on getting a patient settled, but at the same time, a box needs to be clicked that says the patient came into the room. What are you going to do first? You're probably going to take care of the patient, which then means when you go to click the box, well, what time was that? It was probably 4 minutes ago. Maybe it was 12 minutes ago. I don't know. I'll just pick something. Because that just, it's not the priority at the moment.
Of course.
And yet, computer vision can be trained to understand what it looks like to have a patient enter the room, click that box, right? When we know at the end of a case, we know, typically speaking, when anesthesia drops a drape, it's probably 10 minutes before that patient's going to be ready to go to the PACU and go to their recovery. Historically, the plan has been that same nurse is asked to start working with the patient as they wake up, but also run over to the phone, pick it up, call the PACU, let them know that they're about 10 minutes out, and then come back and focus their attention again on the patient. We can train computer vision to understand what it looks like to see that drape drop, automate that communication, send a message to the PACU. Those are some really easy, concrete examples in an operative setting where we can use these kinds of sensor devices with artificial intelligence algorithms to train them around what they're seeing, and then reduce that friction so that, again, those clinicians can focus on the clinical administration of care and not on the box clicking and the data collection, which we desperately need. Like, we're not going to make things better without high quality data that then we can use other kinds of algorithms to crunch and make improvements from. But right now, we don't really do a great job with that data collection, and that's not the focus of our clinicians, or it shouldn't be. And so, we just want to chip away at each of those kinds of things. In a patient room, it's documentation, right? So supporting nurses and collaborating with folks that do ambient documentation. If we've got speakers and microphones in the room, how do we help bring that all together so that in a completely hands-free way, a nurse can have an interaction or a physician can have an interaction with the patient, and the documentation that needs to be done can sort of happen, and nobody needs to have a device.
That's amazing. Okay. So what kind of outcomes are we talking here? In addition to that, we should hopefully see a more satisfied patient, whether they realize it or not, you know what I mean?
Yeah.
Whether they score it differently or not?
Yeah, I think one in an interesting one that really has a substantial impact on other patients is we're starting to see throughput improvements.
Okay.
Right, and so if you think about the number of hospitals that have patients waiting in an emergency room to get to a hospital bed to get the treatment that they need, part of our challenge is that we have inefficiencies that are friction oriented, right, that keep that patient another half a day, maybe another full day, because various things just sort of didn't happen as timely as they could.
Yeah.
So through a combination of care transformation models with things like leveraging virtual nursing, so now that you've got a nursing team that's a bedside nurse and a virtual nurse, they can put the care together in a more effective way and share that responsibility, but also leveraging technology to understand what's happening when. I've equated it to, it's like having a process improvement engineer in every room in a hospital 24 hours a day, collecting information so that over time we can start to say, I didn't even realize this was a challenge, but now we've been able to see this multiple times. How do we dig into that? And so through the combination of the automation, virtual care transformation processes, we've seen health systems that are able to improve throughput, decrease length of stay without compromising quality, which means those other patients who are waiting to get the care, get that care faster.
Really appreciate this. You're kind of opening our eyes a lot and offering this vision of how this can come into play of the experiences of everyone involved. So really appreciate the time here. Any final word, anything else we haven't mentioned?
I would just say everybody who is not thinking about computer vision, start thinking about computer vision, the power of computer vision and where it's going. I think it's going to be the Chat GPT of the next couple of years, we're going to start to really see what computer vision is capable of. And it's going to be an exciting time.
Fantastic. Thanks so much for joining us today.
Yeah, thank you.